Welcome to our short video on QRISK and the risk factors associated with it. The aim of this video is to help you understand more about how QRISK works, what it is based on, and how to use the score and the risk factors associated with it in the conversation with the patient to reduce their risk of CVD. CVD, of course, is the risk of stroke, heart attack or angina in the near future. QRISK is the brand name of the risk tool which has been used by the NHS for the health check since its inception 10 years ago. It was developed by the University of Nottingham and QRISK and EMIS. The score itself indicates what someone's likelihood is of a stroke or heart attack over the next 10 years, and is expressed as a percentage. What it actually means is, if you look at this diagram, if you have a QRISK score of 12%, it means that if there are 100 people exactly the same as you, exhibiting the same risks and the same behaviour, it's likely that 12 of those people would have a stroke or heart attack in the next 10 years. The QRISK calculator is based on research into over 2 million people, some of whom have had strokes and heart attacks and some haven't. Looks at their clinical records, a record of their behaviours, and looks at the correlation between the behaviours which they have exhibited and the fact that they had these episodes. These are the risk factors which the best practice guidance says that we must capture and report in the NHS Health Check. As you can see, age is a risk factor. The older we get, the more at risk we are. Gender is a risk factor. Women are generally less at risk than men because of the effect of female hormones on good cholesterol mainly. Our ethnicity has an impact on our risk. Where our family originate from has an impact on our risk. If there's a family history of heart disease, it does have an impact on our risk. Smoking, certainly one of the biggest influencing behaviours that we can have. Whether we drink or whether we're physically active has an impact on our health, as we all know. Your BMI has an impact on your health, so does your blood pressure, your cholesterol, and your postcode, because deprivation has a direct influence on your risk. If we look at which these risk factors QRISK was found to strongly correlate in the QRISK calculation, you can see that age has a direct impact, gender certainly directly influences your risk, and so does ethnicity. For family history, it was found that only if you had an immediate family member who was under 60, that's either your parents or your siblings, would their influence have an impact on your score. Smoking has a very strong influence, a strong correlation. There was no direct correlation with alcohol and your risk and your CVD score, but of course alcohol, as we know, can influence things such as our BMI because of the calories and our blood pressure directly, so it has an indirect influence on our risk. Similarly, with physical activity, there was no direct correlation found in the research, but physical activity does have an impact on our waistline, on our BMI therefore, and our blood pressure. The BMI, as we said, has a direct influence. It was found a strong correlation with your systolic blood pressure rather than your diastolic, so that is the one which feeds into the QRISK calculation. And of the elements of cholesterol that we measure in the health check, it was found the strongest relationship was with the ratio of cholesterol to the HDL has the biggest correlation with risk than either the HDL or the TC on their own. And deprivation has an influence on your risk independently of all the others. So if you live in a more deprived area, you're more likely to be at risk of heart disease and stroke. Having seen which risk factors have a direct and indirect influence on our risk of heart attacks and strokes, it's also useful to understand the relative impact of each of these. If we look at this diagram, just to look at the relative impact of the modifiable risk factors on one's QRISK score, this diagram shows the risk of someone who is a male who's 50 years old, who has no modifiable risks in the first instance, and therefore has a risk of 4.4%. If we simply make this person a smoker, and that's the only risk factor we add to his results, you see that his risk almost doubles to 8.5, it increases by 4.1%. If you remove the influence of smoking and you give him a ratio for cholesterol of 6, you can see there's an increase in risk there, and as that increases up to 7 in the next column, there's an increasing risk associated with a rising ratio, as you would expect. If we remove those and look at the influence of blood pressure, you'll see what the impact of asystolic of 150 and 170 have. So you can see there's a trend there. If your blood pressure increases, there's an increasing risk associated with having a high blood pressure. Removing those and just looking at BMI, you'll see there's a relatively low impact of BMI just on its own. But it's fair to say that in a conversation with someone, if their only risk was BMI that was a very real concern, you could also state that if they were to bring down their weight, bring down their BMI, they would have a beneficial impact on their cholesterol and their blood pressure, and these are likely to improve as well. We hope this look at the risk factors and their relative impact on QRISK will help you to prioritise the conversation that you have with the patient in terms of which behaviours they should address. Bear in mind, of course, that there are still risk factors at play which we can't influence, the non-modifiables. If you look here, you'll see here that there is a marked influence of age on our risk of heart disease. We all start off relatively low risk in our early 40s, and as we age, our risk increases. And by the time we get to 74, the risk is at its highest. This explains the age range for the health check. Because we're relatively low risk in our 30s, screening will have the biggest influence on our outcomes if people start to have the health check at the age of about 40. And we stop screening at 74 because our risk is relatively high then. It is, of course, a 10-year risk of stroke or heart attack. And it also indicates that a lot of people will be in a care pathway already when they get into their mid-70s. And so the benefits of screening are between the ages of 40 and 74. You can also see there's a difference in gender. Women are at lower risk than men, and this is thought to be because of the influence of female hormones on good cholesterol, on the level of HDL, and the beneficial effects it has on our CVD risk. If you move on to this diagram here, it looks at the influence of deprivation on risk. If you do the calculation for someone at relatively low risk in terms of the modifier behaviours, and he lives in a least deprived or a most affluent postcode, his risk is 3.7. If you then simply move the postcode to the most deprived postcode area, his risk increases to 4.7. So you can see there is an influence there based on where you live, independent of all the other risk factors that you exhibit. And if you look here at the influence on family history of heart disease, you'll see with that same low risk individual, if they declare no family history, they have a risk of 3.7. But if they declare that they have a risk of, they have a family history rather, you'll see that their risk increases to 5.6%. So there's a marked influence of those things. So if you bear in mind the influence of age, gender, and the family history and postcode, you'll understand how these influence the risk alongside the modifiables which are part of the conversation that we have in the health check. We hope this look at QRISK and the risk factors associated with it has been useful in helping you to prioritise the conversation with the patients that you have, help them understand what the risk of their behaviours is, and for them to ultimately say, maybe I should change this behaviour.